The program has changed a little bit because of organization problems. So we will do this tutorial all together, and if you agree. If you don't agree, we will do it anyway. So I'm Edoardo Boccardi, and I come from Italy. That's the hospital I work in. We are going to talk about the flow diverters in the anterior circulation, because that's the talk and the topic that they gave me. And we will play a small game. I have already done something similar before, so for those who have already seen, I'm sorry, but I think it's interesting. And the game is this. I will show you a follow-up, and I want you to see if you know or understand where the aneurysm was. Why? What is the point? The point is that after flow diverter, we have a completely normal anatomy, that you cannot anymore recognize where was the aneurysm. So, anybody who wants to say where was the aneurysm in this case? Nobody? Okay, anterior cerebral artery. Good. Big and large cavernous, intracavernous aneurysm. So it's not possible to tell, because it's so beautiful, the image after treatment, that everything looks normal. And this was one of our first cases in February 2009 when we used the silk, as you can see there. The immediate final result was this, and 6 months later is the image I showed you. And you can see the silk inside the artery, so it's real, it's true. I'm not confusing you. And so this is one of our first cases, and when we saw this, we said, wow! And that was one of the first of many, wow! Because all these aneurysms that we treated, well, we had these spectacular results. So the artery looks wonderful, but how about the aneurysm? Is really the aneurysm disappeared, which is, the reason of the treatment? And for that reason, you need to have something that looks outside the artery. And usually we do an MR or a CT, depending on if there are coils or not. And we want to see if the aneurysm shrinks. If the aneurysm shrinks, it's cured. And so that was the same aneurysm before, and that was at 6 months. Did it shrink? It disappeared completely. That's a beauty. This is another case, very tortuous arteries, very complicated, seemingly complicated case. But finally, we placed, in this case, it was a pipeline, and the follow-up is beautiful again. You cannot really say there was an aneurysm there before. And these are intracavernous aneurysms. Did it shrink? Of course it did. So where was the aneurysm in this case? Any? I'm happy that you cannot really say, because that's exactly the point. So the point is this. And you can see how everything came back to normal. It's a normal artery. And again, that was the aneurysm before. The usual aneurysm, carotid ophthalmic, close to the anterior clinoid. one of those aneurysms where other kinds of treatments are not very good. Surgery, yes, you can do it, but the anterior clinoid is really in the middle of your job. You can fill it with coils, but you know that 2 months later it will be recanalized. You can fill it with coils and put a bare stent, and you know that in 3 months it will be recanalized. So this is perfect. Isn't it perfect? And if you look at the aneurysm from outside, which you always have to look, you see that it's shrinking. Not only it's shrinking, but it's changed color, of course. There is not only a thrombosis, but it's a scar. It's connective tissue, so it is a scar. It's a dead aneurysm. It cannot recanalize. And recanalization is one of the first problems of endovascular treatment. Since the very beginning, we were accused by the surgeons that we could treat aneurysms, but the aneurysm would recanalize. You have seen it today and yesterday probably. But with flow diverters, this doesn't happen anymore. We have a result which is even better than surgery, because we treat the aneurysm from inside the artery, not from the outside. Where was the aneurysm? Sorry? A2, A3. Close. If this is what you meant, yes, correct. So again, you cannot really say by looking at the 6 months follow-up. And you can also see how the artery, which was pushed upwards by the aneurysm, comes down on the angiogram, showing that the aneurysm has shrunk, has become smaller, so it's cured. Again, where was the aneurysm here? I give you some time because it's so nice. And these are not images and cases that I had to choose because they are special. This is every case, almost. So in most cases, you just take any case and you have this kind of results. So did anybody do you want to provide an answer? I see M1, good, wonderful. If they're different, your answers, it's wonderful, because obviously you cannot tell. And you say, oh, this is a small aneurysm. Not really, because the aneurysm is like this. So this is a almost completely thrombosed aneurysm, and you can see very well that at 6 months, the whole artery came down. So you can see that the aneurysm has shrunk just by doing angiography. So sometimes the angiography can tell you if the artery have regained a normal location. They are not anymore displaced by the aneurysm. So if the aneurysm shrinks, becomes smaller, or goes away, then of course the arteries go back to normal. Where was the aneurysm here? Nobody wants to just, I'm not killing you. You will have good grades even if you're wrong, so go ahead. Okay, nobody wants to tell it, but no, I think nobody had. And you see how different it is now. So the big intracavernous aneurysm, which pushed on the middle cerebral artery, now just deflated. Everything deflated. And you can see how big it was, and you can see the edema around the thrombosed part of the aneurysm. This was what it was at the beginning. Those two images, just to tell you that it took 1 hour from the very beginning to of the procedure to the very end, which, if you have to treat an aneurysm like this with coils, for example, it will take 5 hours. With surgery, you cannot even do it because intracavernous, but if you want to do it, it will take 2 days. You can do bypass and all those kinds of things, but if you just do that, it's a simple procedure, 1 hour, and at 6 months, no more aneurysm. Especially, no more aneurysm on CT. It just came off. That was before, and there was a 6 months follow-up. It deflated, it just disappeared. Are these special cases? No, this is what we see every day. 4 years. Where was the aneurysm here? Sorry? A1. Anybody who disagrees with that? Of course, the way we take the images a little bit helps, because usually the problem is more or less in the middle of the image. But that I couldn't do anything about it. This is an incredible, difficult dissecting aneurysm in an 11-year-old girl. I probably will present it in another presentation, but anyway, she had a dissection here with an ischemia, a stroke by occlusion of the perforators. So she had a deep basal ganglia ischemia, which is typical of dissection. Dissection can give, but she had no hemorrhage. But still, it's something that I would prefer to treat. And she underwent surgery before coming to us. The surgeon tried to do something. He opened the head, he went there, and he said, maybe it's better to do it endovascularly. And so she came to us, and we put, I'm sorry, the whole story is here. So this is the ischemia, and this is the aneurysm at the beginning. This is the surgery. She went to surgery, and you can see the stroke here. And the surgeon said, okay, no, better to do it endovascularly. This is an obvious dissection. This catheterization of the middle cerebral artery. And we put a pipeline. And again, this is a 6 months follow-up. You cannot really tell. So it's normal. It's a normal artery. Another kid, 11-year-old, again, male, who came with a left hemiparesis. Same thing, you see, a dissection of the M1, which brings to an ischemia of the deep basal ganglia. And, but there is an aneurysm, and this is the aneurysm. And again, another flow diverter there, pipeline. Before, at 2 months. It's shrinking. If it shrinks, it's cured. Where was the aneurysm? And nobody wants to answer anymore. Too many wrong answers. Okay, so it looks like here it's not completely normal, and in fact, this was before. This is a fusiform, not so easy case. Why it's not so easy? Because you have the ophthalmic artery, which is exactly originating from the middle of the fusiform aneurysm. But as you can see, the ophthalmic artery is still there. So this is the aneurysm before. Place the flow diverter, and the 6 months follow-up. It's disappeared, and you can still see that the ophthalmic artery still is there. What do we do in subarachnoid hemorrhage? We talked about that before, and we will talk about that more in the future. This is a 36-year-old lady. Not a good CT scan, because you can see that there is a subarachnoid hemorrhage and also some big brother there. And what we do now is to take it in 2 times. When they are so big, we tend to coil it in the emergency time in order to protect it from a acute rebleeding, which we know it happens. And then after a while, so we coil it. A lot, not a lot. Enough. Enough to protect it. But we know that will be a recanalization. Do we want to go all the way down to the neck and to complicate the procedure? No, this is very simple. You do that, you put coils, you put enough coils, and you wait. You know that whatever you do, it will recanalize. So why do it too much now with the risk of thrombosis and everything else, and the cost, of course? 1 month later, there is, of course, a recanalization. That's exactly what we expect. So the second step is to place a flow diverter. In this case, it was a Fred. And the 6 months follow-up, of course, everything is gone. In this case, I cannot ask you where the aneurysm was because it's very obvious. But if you look only at the artery, it's really normalized. And the idea is that usually if you have coils inside, you will understand that the aneurysm has become smaller because the coils will come down close to the stent. What does that mean? That the blood that was pushing the coils away from the stent, there is no more blood. The thing is just stagnating, and then it's thrombosing, and then everything just comes down. And this is what we call the sleeping coils that go to bed on the stent. This is another example where we did exactly the same thing, and you can see how the coil mass just changes position and just comes down on the stent because there is no more aneurysm. You are only left with coils inside a thrombose, not thrombose, it's really a scar. It's more than thrombose. It's thrombose which has gone through all the process of becoming a connective tissue in the region. Another hemorrhagic case, this is a 50-year-old man with an acute subdural falx hematoma. I don't show you the CT scan, but I show you the culprit. So this is the aneurysm which caused the hematoma, and it's kind of a strange aneurysm. It's probably a dissecting aneurysm of the very first part of this branch. So it's not on the bifurcation, it's just a little tiny bit distal to the bifurcation. What can you do? Okay, here you can see it better. You see how it stagnates, which is typical of dissecting aneurysms. So which is the best treatment? In this kind of aneurysm, occlusion of the artery, of course, is the usual possibility. Surgery, yeah. Probably the second best treatment is coils in the sac, but we know that these aneurysms tend to recanalize and not being stable because you don't have a nice wall around it. And an optional treatment that we have assumed in the last few years is to put a flow diverter, as I told you this morning about the case of the vertebral artery, pike artery. This morning, well, you can place a flow diverter. This is at the time of the placement, not in the artery where there is the aneurysm, but on the major artery where the secondary artery comes from. So very close to the origin of the diseased artery. What's the point of doing that? The point is to change the flow inside that branching artery. And by changing the flow, of course, everything goes away. And you may say, well, you occluded the artery. Did we occlude the artery? No, it's still there. So we just remodulated the flow inside the artery in order to make the aneurysm disappear, but maintaining the flow in that branch. Or even if the branch is no more visible, it took time before occluding completely. It is not an acute occlusion. If you occlude an artery from immediately, you may have a stroke in that territory. But if you let it do slowly, what happens is that there are collaterals which will grow. And we have seen many arteries that have slowed down and then finally go away, but without any symptom, without any stroke, because in the meantime, there are the collateral formation. And so it's a slow occlusion, which is much better than an acute occlusion. Cases like this, we have seen one today, I think. By placing a flow diverter, again, the aneurysm is no more there. Also, A1 is no more there. But you know that A1 is a typical situation where you can have flow from two sides. Nothing bad happened. Another case in the same location. And again, you see that the coils after the treatment just come down on the flow diverter. They just go to sleep. This tutorial was meant to be 15 minutes. I can go on forever, but I go on? Okay. Do you want me to go on? Yes. No. Okay, so other cases. This is a 17-year-old girl with headaches and problems in menstruation, and she has this monster on the side of her sella. This is the aneurysm, not a nice one. What could you do here? Of course, occlusion of the artery. That's the best treatment for big, large, giant aneurysms. Can we occlude the artery? It's very low flow in those two, both in the communicating posterior and both in A1 on the other side. So no, it was not possible to occlude the artery. We could have done a bypass and occlusion of the carotid. In this case, it was decided we might try flow diversion. And I make it simple now, but these are a few flow diverters that were used, one inside the other. Why? Because we had learned that in order to have a good channel inside these big lakes, big aneurysms, you need to have a very strong channel. So one single flow diverter will never take care of the shrinking of the aneurysm, of the thrombosis inside the aneurysm, of the formation of the scarring inside the aneurysm. So you need a very strong channel. So that's why we put all these flow diverters. You can see that at a certain point we had a separation. Is that one? No? Well, maybe I will show it to you when the lecture will come. So we had to do a lot of maneuvers to get there. At 6 months, she was already asymptomatic, and we had a follow-up, but I will show you now the follow-up at 18 months, and you can see how the artery looks like, but especially the important thing is that the aneurysm has completely disappeared. And the girl is marrying next year. Okay. Another monstrous case is this case. This is a 22-year-old male. He was 22 in 1989. He has an Ehlers-Danlos disease, and he came because he had a rupture of the carotid artery in spontaneous, like Ehlers-Danlos patients have, in the cavernous sinus. So he had a fistula. And it's an 89 case, and so you will see how we treat it, how with balloons, the ones that you were presented a little while ago. And you can see that the fistula was occluded by the balloon in 1989. So nobody touched him anymore. You don't want to touch Ehlers-Danlos patients. But 20 years later, in 2009, he comes with cranial nerves problems and proptosis. And this is what he has. So a monstrous, thrombosed. This is not really an aneurysm, it's a pseudo-aneurysm. It's the venous part of the cavernous sinus. As usual, when we did this procedure with the balloon after a while deflates. And if the deflation is inside the cavernous sinus, of course there is a little pouch of the carotid inside the cavernous sinus. Most of the times, this pouch is completely asymptomatic, no problem. Sometimes it becomes bigger. And especially in an Ehlers-Danlos patient, this is what it did. And this is really, oh, you can see the balloons here, see? And what can you do? You don't want to sacrifice an artery in a patient who already has problems with our arteries. You don't want to go there with aggressive systems. So what we just did was to place 3 pipelines. These are all the old type of pipelines, but again, it was some time ago. And you can see the progression. You see the balloon. And finally, we built a channel in that region where the origin of the aneurysm was. And this is the 1-month follow-up, and that's a 1-year follow-up. But this is the 3-year follow-up. So this is fantastic. I mean, there is no other chance of having such a beautiful result. So everything just goes away. It shrinks down. And in a patient who had a lot of risks in everything we did. Other examples. What happens when you have bilateral aneurysms? Well, you do it one at a time. In this case, we put coils. And then after a while, in this case, we place the flow diverters without coils. And so the 2 aneurysms just were treated and cured with flow diverters. Again, there is no other chance of having this beautiful result with other treatments. This is another, I think, lady with a loss of vision in both eyes. And we did this, okay. And you can see the before and after. We treated both sides with flow diverters. And there was, of course, an improvement of the sight in this case also. I'm not remembering where I'm going, so just stop me whenever you want. Another difficult case. So this lady had a subarachnoid hemorrhage by this aneurysm, which you can see the neck of the aneurysm starts here, ends there, and so a pretty big neck. And where she was, she came to the hospital, not our hospital, they decided just to place some coils. But of course, it's impossible to place coils with such a wide neck. So she finally came to us. And you can see again that the neck is all the way there. So we placed the flow diverter. And at 6 months, the whole thing is cured. You can interrupt me whenever you want. I'm sorry, I didn't say that, but it's obvious. We are in a tutorial, so please, if you want to say something or ask. But especially, we want to see what happens to the aneurysm by looking at outside. It shrinks. If it shrinks, it's cured. One of the regions where we can place flow diverters, and we have placed flow diverters since the very beginning, is the anterior communicating location. This is not really an anterior communicating, I'm sorry, but we have quite a number of those. And again, what we did was to place a pipeline. And you can see it here. And at 6 months follow-up, there is only a little tiny part of the aneurysm or of the anterior communicating. And it shrinks. Oh, we go back to the initial. Where was the aneurysm here? Do you believe there was an aneurysm here before? M1? Above or below? It's easy because it's the only thing we see, so yeah. But it was middle subarachnoid bifurcation. This was the aneurysm. This was at the time of the deployment of the stent. And this is the follow-up. Difficult to say that there was an aneurysm here. Here, I don't know if, yeah. Here, what you see here, it's an interesting part of what we do, which is the fact that the branches, this one, becomes, as I told you, this one. So it shrinks down, also the branch, but very slowly. So no symptoms, no stroke, no problem. But the interesting part is that you always see kind of a jump between the main artery and the branch. It's like they are not in direct communication. We call this a ghost connection, something that you don't see. And we see that very often when you have branches coming out of the flow diverter part. And so far, this has not caused any problem. We're talking now 10 years of experience. But it's something interesting, and it deserves an analysis. So that was a bifurcation aneurysm, should be. This is probably the first case where we did it. It's a middle cerebral artery bifurcation. You can treat it in 100 different ways, but we decided to treat it with a flow diverter, a pipeline, as you see, 2.5. This is immediately, and this is the 8 months follow-up. So it works. Even here you can see the ghost connection. It's like a little jump between the main artery where the flow diverter is and the branches coming out. Other cases in middle cerebral artery, again this one, and you can see how the coils come down on the artery. This again was the one I showed you at the beginning with the aneurysm, which is that big, and it goes to normal. And you can see also here that the branch, this one, has become this one. Is it worrying? Do we worry of this? At the beginning, we were kind of uneasy, but we have seen with time that nothing happens. Maybe the time is a little bit short, 10 years, but still. So we don't know what will happen in 20 years, 30 years. What if a branch is not anymore there? There will be collaterals. But the collaterals are always safe, or they go through places where the artery are smaller, and what happens, we will see. You will see, because I will not be there anymore. Another case. Okay, so probably it's finished. I don't know. No. Yes. Okay, I don't know if, I'm sorry, because the presentation was supposed to be half what I presented you. So I don't know where I'm going now, but maybe this is the case number 2 in our hospital. This is 2 October 2008. And we did 2 cases, and this is the second one. And we placed flow diverters there, and you can see the flow diverters with the CT at 9 months, which just have this nice picture. But what's interesting about this case is that, of course, we did a CT scan immediately after the procedure, like we always do with all cases, all procedures. We want to know how the brain is immediately after our treatment. And as you can see, it's perfect. At 4 days, it was the second case. We wanted to check with a CT angio. She's okay. Of course, she's a little bit headaches, because when you do a treatment in your head, you may have headaches. But the CT scan showed this. So this is one of the first cases, I think, in the world, where we showed one of the complications of flow diverters which were not seen before. This complication is an intraparenchymal hemorrhage, hematoma, in the distal brain, not close to the aneurysm. It's not a rupture of the aneurysm. The aneurysm is down below here. and you have hematoma far away in the brain. So this is one of the first cases where we showed that you could have this kind of complication with flow diverters. And there have been a lot of discussions why with flow diverters you have this complication that we did not see before with any other. Does anybody know the answer? No. It's a good idea, and it was one of the many things that were, and we really don't know. But the point is that it has become less and less over the years. In the recent, like say, 5 years, 6 years, we have seen very few of these. There were many more before. What has changed? I think what has changed is the preparation of the flow diverter when you insert it in the catheter. Why? Because we think that with all those struts very close to one another, and you put it in the catheter, there is a lot of air which has not been flushed because it's trapped by the struts of the flow diverter. And so when you go up and you release it, there are micro bubbles of air going in the brain. And so since many years, we started to flush, and all the companies will tell you to flush the flow diverter very much. And we even gave it a little hit in order to push the air away from the device before inserting it in the catheter. I don't know if it is this, but certainly now this complication is more rare than before. It was, at the beginning, it was around 3%, and now we have done registries of the Derivo, of the Shield, of the, all the new stuff, and it's almost disappeared. So I don't know if that is the reason, but if it were the hyperperfusion, it would still be there. We would have the same complication rate because we are still doing the same things. And so for the other possible causes. Also because it does not happen with, for example, with the normal stents. So even with normal stents, you rearrange the flow in the artery, normal stent and coils, but it does not happen. So there was something specific to flow diversion. If you find the solution, I will be happy. Another, you tell me if I have to stop. Another important message is that we were not happy with our results at the level of the posterior communicating artery, when the aneurysm is large and giant. And this is the first lady, 8-year-old, who had all kinds of vascular diseases, and she had this aneurysm. Large aneurysm of the posterior communicating artery. And you can see what it was angiographically. And we placed the flow diversion, a flow diverter. We couldn't occlude the artery. We placed the flow diverter. And the follow-up at 5 months was this. Not really what we wanted, especially the aneurysm. I hope you can see it, yes. It's become bigger. Can you see it? When the aneurysm becomes bigger, it's a problem. It's no good. Also because you have lost your way to the aneurysm. You cannot enter the aneurysm anymore. And after a while, she dies. We don't know exactly why, but anyway, she was 80. She might have died because of brain problems. But that was the first case. Another case, 66-year-old woman with acoustic hallucinations, and this is the aneurysm. Again, in the region of the posterior communicating artery. No far. We place a flow diverter, as you can see there. This is the immediate, and you can see that there is a big stagnation of contrast in the aneurysm. And this is the 5 months follow-up. So you would say, wow, it's almost cured. Is it? In reality, she becomes symptomatic, and the aneurysm is still smaller angiographically. But if you look at MR, this is what we are. It was like this at the beginning, it's like this afterwards. So there is a thrombosis, almost complete thrombosis of the aneurysm, as you have seen, but the aneurysm is still growing. And this is a problem. Another case, we are, around 2010, 2011, another posterior communicating artery, large aneurysm. We treat only large aneurysms. And again, you cannot occlude the artery, blah, 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 blah. And so this is the flow diversion. Looks nice. There is stagnation after the treatment. We are happy. 6 months follow-up, and you can see that the aneurysm has become bigger. Maybe I think I have, yeah. And you can see it also on MR. It was like this before, it is like this now. So we do a second treatment. Why, how? Placing more flow diverters. And we did place more flow diverters, exactly 2 more. So now we are at 3 flow diverters, one inside the other. And this is what we see after the 3 flow diverters immediately. Of course, there is still a passage, but it's interesting to see the way the flow goes inside the aneurysm here. Look at that. And I go back just for those who have not seen it. So it's like a very tiny, very small jet inside the aneurysm. It's like a little hole, and it goes inside the aneurysm. And if we inject the posterior circulation, the vertebral artery, this is what we see. So you might not consider this, but if you look, see how the flow goes back and forth in that artery. Boom, 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 boom. See? Which means that there is an unbalance of flows inside the posterior communicating artery. And that posterior communicating artery is exactly at the level of the aneurysm. Here we did a carotid compression, and we injected again in the posterior circulation, and you can see where the posterior communicating artery is entering here, and then from here directly in the aneurysm. And it's going back and forth. Every heartbeat, you can see how the aneurysm is growing. And this is another, this is where we want. So the explanation for me is that if you have this kind of situation, which is a situation where you have the posterior communicating artery, and you have an aneurysm here, and you have a little jet of something from the carotid, but also something coming from the other side, these flows, who are not convinced, they don't know exactly what to do, keep blood entering the aneurysm, and that's a problem, because that's how the thrombus and the thrombosis and the clot is becoming larger and larger and larger, because there is flow of blood coming in contact with the thrombus. Another okay, no, I think I'm finished. So thank you very much. Yes, sorry.
Regarding literature about aneurysm treated with a flow diverter, it has been described delayed rupture of aneurysm in case of very large aneurysms. And you show us very nice cases without any coils. So how do you decide that, and what is your position about that?
Thank you. This was supposed to be a tutorial. The lecture on flow diverter will come, I think, tomorrow or the next day. But you can wait for that, or I can answer immediately. So we have had ruptures of unruptured aneurysms, very big. At the beginning, again, at the beginning of our experience, that is 10 years ago, our case, which rupture, was one of the first cases in the world where we understood that aneurysm after flow diversion could rupture, even if they were unruptured. But all these, after looking at the cases, they were large or giant aneurysms. And so since that case, what we do is to place coils inside the aneurysm before flow diversion, or at the same time of flow diversion, in order to avoid this complication in those aneurysms where we think the risk is high. Who knows? Nobody knows. But the registries that have been done years ago showed that the risk of rupture was higher in larger aneurysm, and more or less it did not happen below the 12-15 millimeters. So now we certainly put coils from 15 millimeters up if the aneurysm is larger than 15 millimeters or more. We might be, we don't put coils if the aneurysm is 12 millimeters or lower or smaller. Between 12 millimeters and 15 millimeters, we have to decide case by case. Some aneurysms look more dangerous, some other aneurysms look more benign. So it's case by case. But certainly we put coils when the aneurysm is large. And in this way, did we stop completely the hemorrhages or the ruptures of aneurysm treated with flow diverters? No. But once again, at the beginning, there were more or less the 3% of cases without coils. And in the very last registries, we probably are down below 1% without coils. So probably there is an effect of coiling and there is a protection. Is it a very dense coiling? No. What we do is you have seen some coiling cases. what we do is to place coils which have to be more or less everywhere inside the aneurysm, not just in one side and the rest is open, but coils have to fill the whole aneurysm, but not very densely, not all black. You don't need that. It's usually we place 5, 6 coils, 7 long coils, like 40 centimeters coils. These are large aneurysms, so you can just push a long coil and it goes where it shall go, and then they push another. So in 5 minutes, more or less, you have finished with the coiling. Any other? Yeah.
Dear Professor, 15 years ago, one of the widespread treatment of giants and large aneurysms was using the conventional type of stents such as neuroforms or enterprise with coiling. And did you have experience of
stent and coil?
Yeah, no. When even after half year of the stenting, we observe, or maybe more later, we observe the recanalization of aneurysm. Do you have experience of putting a pipeline or other flow diverting into the enterprise stents?
Again, very good question. Again, something we will talk about also in the next in my presentation. But if you already have a stent in the artery, it's better not to flow divert, because the stent, especially the enterprise, but also every stent, is not on the walls of the artery, but it's in the middle of the artery. We don't see it, we don't know what it is. Maybe today with the new machines you can also see what it is, but usually it's in the middle of the artery. Flow diverters function if they are very well opened on the walls of the artery. So if they are not on the walls of the artery, they are more a problem than an advantage. And we understood, again, this in the very first cases. If you go with a flow diverter inside another stent, it has to be a stent which is really on the walls of the artery, because if there is a curve, for example, it will always be in the middle. In the basilar artery, it's easier because it's straight. In the vertebral artery, it's easier because it's straight. But in the carotid siphon, it's going to be a problem.
And what is the option of the treatment?
Sorry?
What is the option of the treatment? What have to do?
Usually, the best is to occlude the artery. And this is feasible just because there are collaterals, or because you can do a bypass, surgical bypass, and then occlude the artery. So if you really want to treat these aneurysms, sometimes we don't know if the stent is really, where is the stent? We don't know. So we go there with a balloon, and by inflating the balloon, you see if the balloon is inflating very correctly, then you are in the middle of the stent. But if the balloon has some places where it's smaller, so it goes like this, it means that the balloon is going through the stent. In that case, don't place a flow diverter. But if you see that the balloon is very nice and opens very well where you want to place a flow diverter, then you can risk to do it, because it means that you are in the middle of the stent. We have done that some time, but it's not an easy procedure, and it's not easy to understand where you are with your catheter and with your balloon, because of course when you inflate the balloon, a normal stent will just move. But when you place a flow diverter, it will stay closed, and the flow diverter will not be in the correct position. And if the flow diverter is in the middle of the artery, not on the wall, but in the middle, it's terrible, because it will occlude the artery. It's a dense mesh in the middle of the artery. So don't do it. If you can, don't do it.
Thank you. And the last question is concerning the bigger and large artery aneurysm at the angle of the ACA and A1, A2, when there is no, when both atria arise from the side of aneurysm. What should we do? Is it safe to put the flow diverter in that case?
Yeah, we have done that many times. I'm sorry I don't have cases here. So when you have the two A2s coming from the single A1, you may decide to go across the anterior communicating artery in the A2 of the other side, or stay on the same side, and both things are feasible. It depends usually where the neck of the aneurysm is. So if the neck of the aneurysm is on the communicating artery, it's better to go across, to place the flow diverter in the communicating artery. But if the neck of the aneurysm is more on the origin of A2 on the same side, then it's better to place it on the same side. Of course, these are general. You just look at the images and you think, what is better? What does it look better? In both cases, it works in most of the time. And the other thing you can do is, if it's on the communicating artery, as it has been shown before, you can place two flow diverters, A1, A2 on one side, A1 and 2 on the other side, what we call the kissing flow diverters. Or I've seen also placing X flow diverters. But you need to have a very big communicating artery, because otherwise it will be, both of them will be crunched. So you need to have a lot of space to let the two flow diverters to expand correctly. I've never done it. I've seen it doing it, but I've never done it. Thank you. Thank you.